Thank you very much, Chair, and thanks to the organizing committee for the invitation. I think you've made my life very easy. We've gone through the anatomical scan, and I think the question is to really sum up what my colleagues have rightly discussed and the potential that is available, but also to take this opportunity to try and reflect what we can do in Africa. And I'm quite aware that there will be a discussion later on what's happening in different countries. Okay, sorry. Okay, so my outline is introduction, look briefly at what's happening in the global world, and then I'll talk about the role of ultrasound, talk about the challenges, and then I'll conclude by looking to the future. So I think we are all aware of the global challenges and burden of child death. And this really revolves around the issue of, under 5 mortality, as well as stillbirth, and the condition that contribute to this. And because of these challenges, together with the challenges in maternal mortality, which we are all aware of, the world has come together to set out the Sustainable Development Goals 2030. And in particular, I want to look at 3.1 and 3.2, the target of which is to reduce the under 5 mortality rate to less than 25 per 1,000 live birth by 2030. And in terms of natal mortality rate, that figure, it's about 12 per 1,000. Apologies for the missing zero there. And if one look at what's happening currently, and I'm gonna look at the 2020 data, just to give you a snapshot of what's really happening in terms of this progress. When we look at how we have done since 2015 up to now, initially we saw a global reduction in maternal mortality in certain areas. So there have been pockets of excellence, but majority of countries in Africa haven't really done very, very well. So we still have close to about 6,700 newborn deaths daily, and 47% of those are deaths under 5. But when you look at where these deaths are coming from, 80% of those are coming from Sub-Saharan Africa and South Asia. And in particular, if you look at Sub-Saharan Africa, we contribute about 44% with global stillbirth. That translates to about 2,300 stillbirths per day. And we also contribute to the highest natal mortality. I think the average figure is about 27, but when you look at the range in different countries, it ranges between 25 and 32. And even some countries are even higher than that. And of course, you can look at what's happening in Southern Asia, which is sort of our siblings in terms of the challenges in maternal and neonatal and child death. And they doing a little better compared to us. The average is about 23. So when you look at this data, the other data is telling you is that if you're a child in South Africa, you have got 10 times more likely chance to die in the first 28 days compared to other places. And the causes of the death in Africa, in particular, in low-income countries, preterm labor, intrapartum complication, infection, and congenital anomalies. And if you look at the general figures, it's estimated around 2 to 3% of general population. We don't have really robust data from Africa, and these are sort of global data. So you can see that we do have a challenge when it comes to congenital anomalies. So I think my colleagues have given us a very good presentation as to what we can do in terms of ultrasound. But I just want to remind you that the ultrasound that revolutionized the care of women and pregnancy generally. We have seen how ultrasound had contributed to reduction in maternal mortality, by identifying pregnancy complications such as an ectopic pregnancy, which led to timely interventions, screening for pregnancy complications like preeclampsia, preterm labor, and all the other issues that were presented before, and as well as screening for congenital anomalies. So there is no question about the value of ultrasound. I've already mentioned about regarding the general prevalence of congenital anomalies. I think the challenge is, how can we provide this service? So we know that if you look at congenital anomalies, 50% of major anomalies can be detected in the first trimester. And I'm glad that we have been taken through how to do a scan in that. And of course, when you do fetal anatomy, the detection rate is probably about 50 to 68% in the general population, general specialist, and about 75% and higher with experts, and with a false positive rate of about 10%. So that tool is available, whether you're looking at the general population, non-subspecialist practitioners, you can see that even if we pick about 50% of those, will have done a use service to the community. We also know, looking at the first trimester that Dr. Verenga presented earlier, that most of the anomalies, major ones, they actually develop, more than 80% develop at around 12 weeks, before 12 weeks of age. And what it does, if we could provide a first trimester fetal anatomical assessment, we can reduce the diagnostic time for severe structural anomalies, which will give us sufficient time for parental counseling, early termination, which is associated with less morbidity. And of course, in some areas, we'll actually be able to overcome the legal challenges in terms of what can be terminated and what cannot be terminated. And I think the unit of Prof. Ngolaides have shown that there are certain conditions that we should be able to pick all the time. And of course, there's some that are challenging, and there are some that we're probably not going to be able to pick in the first trimester. But it's very important to look at those ones that we'll be able to pick. And that's why it's very important for us to have that information in mind, so that when we perform first trimester ultrasound, we can look at those. And I think Dr. Verenga again spoke about and showed us pictures of those conditions that we can pick. And he also spoke about the importance of the standardized protocol to be able to pick those anomalies. However, there are huge challenges in Africa in terms of booking. Majority of patients book very late. If you look at studies here in South Africa, we've got a very poor early booking, despite years of trying to encourage women to book earlier. But also got a challenge in terms of resources. It will be interesting to hear what's happening in other areas, because if you look at what's happening currently in most centers, the centers that are in urban areas, in cities and towns, are the ones that are doing very well. But once you move out of those centers, you probably will not find even a fetal medicine specialist or even fetal medicine services, never mind all these advanced techniques and technology that we have. And that really limits of what we can do. So what have other countries done? Again, this is data from the National Health Service in the UK, where they have looked at introducing a national program. So they start with a first trimester screening, your NT combined test. If you don't have that, then you can look at your quadruple test. And that is followed by fetal anatomy at 18 to 20 weeks. And then, of course, you need to look at they had a minimum of 11 conditions that everyone should be able to pick. And these were based on the fact that those could be treated before or after birth, or at least can be improved by arranging delivery and maximizing the condition around delivery. Or they look at this condition that the babies were most likely to die after birth. That was very important in terms of counseling. And should anyone pick any of those conditions, then we'll be able to refer for confirmation, counseling, and further management. And subsequent to that, then you can see on my right, I don't have a pointer, you can see the performance of the ultrasound in those identified conditions. And of course, you can see that when it comes to cardiac anomalies, the detection rate was a little bit lower. But despite that, things like hypoplastic left heart, those things we should be able to pick because they're quite easy to identify. There have been other studies that have looked at adding more condition on that. And of course, if you look at that, all the studies are suggesting that it is possible to run a national program, even if we don't do a very comprehensive list of stuff, but teach people to identify the core issues that affect our neonatal outcomes. So everyone has to say that, what should we do, having heard from the speakers and all the things that they've shared with us today? If you're in an ideal situation, probably what you need will be NIPT with an expert nuclear done by an expert, and a fetal anomaly scan at 11, 13 weeks. And then once that is done, then you have a second trimester fetal anomaly assessment. However, if you look at this will be able to pick most of the conditions that we deal with, both chromosomal and structural. And some people have been suggesting that we should actually add a third trimester ultrasound, and probably that will help in terms of CNS anomalies and give an opportunity for us to do neurosonography. However, this, as you can see, is probably in a country, in a setting where you've got all the resources, and this is out of reach of many. What about other options? The other option is to look at divide our patient into high and low risk. And for high risk, we've got an expect NT, an early fetal anomaly assessment. If you can add biochemistry, that would be great. But I know, for example, in our settings, we don't even have biochemistry in the public sector. And if your risk is more than 1 in 100, then you can offer invasive testing. If you are between 1 in 100 and 1,000, and you can have you got access to NIPT, maybe that should be offered. In cases where you don't have that, maybe, and you've got an expert to perform genetic sonogram, that probably should be the way to go. And I think that also will assist in picking some of these conditions that contribute to poor outcomes. In the low-risk setting, if you got access to biochemistry, then you probably should be doing biochemistry and fetal anomalies. And this probably will refer to a generalist and when there is no access to NT. But if you've got an NT, which we should probably be striving to, then we should be looking at NT. And if you've got access to combined test, then a combined test. And then we'll refer to an expert if there's high risk or there is any concern. And I think there's a question there that was asked, and in the South African setting, unfortunately, we don't have all those things. You only get this in university-linked centers. And if you, in the public sector, that's the only chance that you get. And even then, you'll probably find that in some of the provinces, the 9 provinces, there's probably nothing that you can access. So what we're even seeing now is that even in the public sector, in the private sector, it's very expensive to actually get access to screening. You often need to go and see a fetal medicine specialist, and it's not cheap. And then you'll be referred afterwards for genetic sonogram, again at a high cost. So most of those things, even in countries like ours that's supposed to be low to middle income countries, those things I dream are not accessible to many people. So the thing that I think we really should be looking at is we probably should strive to train everyone into performing endocrine assessment in the first trimester and to do basic fetal anatomical scan. And then we then go on to teach people how to do basic fetal anomaly training. We train doctors and nurses and midwife, and that data that suggests that that can be done. And we do even have a local data here of a very small project that was started by one of my colleagues that actually showed that you can train midwife and they're able to identify fetal anomalies and refer to specialist centers. This probably is one of the things that we can be able to do in areas where we have got challenges. So we've got serious challenges in terms of providing anatomy, and we must be real about it, that all the stuff that colleagues have showed, I suspect that is because they've got facilities, and it's a high resource centers, or at least they've got access to that. Majority of people in the rural areas and other provinces will not get that. So there's no congenital anomaly screening progress in most of the countries, including South Africa. And part of it is really a lack of political will. And I would really like Dr. Verenga to hear how he actually managed to put something together and how far that program has gone in terms of going outside Harare to other remote areas, and because that's where there's a need for this kind of stuff. And we've got the problems with resources. And it's one of the limiting factors. Ultrasound machines are very expensive. I mean, even us who are in the tertiary centers, in some cases, we even struggle to get good quality ultrasound because the government doesn't have money to do that. And of course, then we've got the problem of expertise, which is one of the areas that I think we should be able to address. So really, if I were to conclude, is that we do have a high burden of child death in Africa, and this has got a physical, psychological, economic complication or implications. And we really need to start thinking about getting a national screening program. However, that will need us to invest in resources and try and advocate for patients so that we can get political buy-in and try and put lots of effort in training everyone that this does not become only accessible to the privileged, but to everyone that actually need that. For example, in the South African countries, 15% of patients are the only one who can access private sector services. 85% depend on the public sector. And those patients, in most cases, are not able to even get access to screening, never mind an anatomically scan. And that's where I think we need to put our head together and learn from all the individual countries that have implemented some programs so that we can also provide these services to our mothers and their children. Thank you very much.